Morning. Uh, Welcome to Depression and Psychosis, Creating New Pathways for Recovery. And Brian was modest. He not only looked at it, gave me a lot of good input and suggestions. So crediting him on there for part of this. For sake of time, I'll just kind of blaze through it, but he was super helpful in pulling this together. So I appreciate that, Brian. Um, so what are we going to do this morning? The objectives, I'm going to try to go over and a little bit differentiate the difference between negative symptoms and depression in psychosis, and then talk about some common pathways to depressive symptoms and psychosis. So how do they connect? How do we get there? And then describe areas to target when depressive and psychosis symptoms co-occur. And so that particular combination. So, we know CBT is very was developed out of treatments for depression. But when psychosis occurs, what are some particular things we might pay attention to there? So moving along. So the first slide that I have here is just a little slide about differentiating symptoms. So on the left is the column for depression, essentially the symptoms from the DSM. On the right is symptoms of, or the characteristics of negative symptoms. And I just took the liberty of highlighting, based on the research, the factors that seem to differentiate the two. So on the depression side, the depressed mood really stands out as one of the differentiating factors. And contrasting it with negative symptoms, we often see a flat and blunted affect. So it's kind of the sadness down versus more blunted, I don't really have much emotion to speak of or that I'm going to report to you. The other parts of switching over to negative symptoms, the differentiating factors, the other one is kind of a slowing or poverty of speech, where there's just limited speech that's occurring at all. And one of the interesting things that I found in Anthony Morrison's book on CBT was that individuals that were in a hospital, individuals with depression who had poverty of speech, when they departed the hospital, that improved. So they spoke more, got more active with their quality of speech and amount of speech. Individuals with schizophrenia, when they departed the hospital, that symptom actually intensified or got worse. So it kind of stayed the same that way. So a differentiating factor there. Moving back to depression, besides the mood, we're really looking at the kind of characteristic, if you guys remember the cognitive triad of depression, right? So these are the things that Beck originally identified, these depressogenic thoughts that individuals have. So individuals with depression report negative or pessimistic views of themselves, so kind of the worthlessness piece, negative views of the future, so there's pessimism, and negative views of other people. And so those cognitions were more prevalent, more present. There's almost a activating scheme that was there. So a lot of events that happened got filtered through that cognitive triad. And of course, at the extreme end would be thoughts of suicide. Why do we talk about depression within schizophrenia? Well, the prevalence is pretty high. It's fairly common, around 40% at any given point. Individuals with schizophrenia will report depressed mood or co-occurring major depression. And when looking at it longitudinally, up to 80% in various points in the early phase will show signs of depression. It's important because when depression is present, it is the most significant factor in a completed suicide. So even more so than command hallucinations. Command hallucinations, they're dramatic. They tell the person to hurt themselves, but it's really depression and presence of more severe depression that's going to be a driving factor there. It's also important when we think about uh, transition from a clinical high risk state into psychosis. Depression is present early on, and this is clear in the literature. And as a little sidebar, some of the work we did with the local agency in the clinical high risk space, what we noticed, individuals that were reporting with clinical high risk symptoms were also reporting depression and anxiety at quite high rates as well. So we're going to talk about one of these three pathways from depression to psychosis. So Birchwood and colleagues proposed this idea that there are three ways you get to depression in schizophrenia or psychosis. One is that depression is just a core dimension of psychosis, so it's almost intrinsic to it. And they're really speaking more at a neurobiological level, and I don't really have the expertise to go into the details, but the presence of depression, they speculate, kind of drives some of the further symptom development through kind of a stress, inflammation, structural brain change pathway. And I can't really go into more detail than that, but it's just sort of intrinsic to it for some individuals. The second pathway is the one we're going to spend more time on today, and that is depression occurring as a psychological reaction to the experience of psychosis. So, experiencing voices or persecutory delusions, a person gets in a certain state, this kind of subordinate state, is one pathway, and another has to do with kind of internalized stigma. We'll go into more detail in a little bit. The third pathway is that depression is evidence of childhood trauma. Interestingly, if you just look at the correlational data, having a history of trauma, are 2 to 15 times higher in individuals with depression with psychosis versus non-psychotic depression. We know that, traumatic events and so forth are a common factor that potentially could put a person at risk for psychosis. But when depression is present, kind of raises the radar that this is something really to pay attention there. So in the second pathway, depression is a psychological reaction to the psychotic experience itself. Let's talk about that a little bit. The theory that Chadwick and Birchwood and that group came up with is what they refer to as social rank theory related to voices. And this is based on evolutionary kind of concepts about how our brain developed over time. So the experience of hearing a voice is often associated with feeling entrapped, right? So the voice is often seen as powerful and omnipotent. When we as human beings are in a position where a dominant force is controlling us, the kind of biological response is to behave more passively and submissively, kind of be subordinate. So that's the lower rank response. And of course, it's associated with less power, less control, and can also be associated with feelings of humiliation and shame. So you have that lower rank position, and you're constantly vigilant for threats. And so those two factors themselves can be depressogenic, if you will. The second factor that they found from this research, it's kind of interesting, is they found that the person's relationship with their voices, how they felt in relation to their voices, often paralleled current interpersonal relationships. So family, supports, other relationships. So there was kind of a parallel between the voice and other relationships. So that becomes another target for us to kind of pay attention to. The end result of that, and you can imagine it makes sense, right? Where you feel marginalized, loss of sense of self, depowered, depression is a result of that. And they did a specific study where they looked at individuals' thoughts about their voices, their appraisals, and found that 2/3 of voice hearers reported at least moderately depressed mood attributed specifically to voice hearing. So, and this is just a typical maintenance formulation that we might develop in CBT, pulling in these components. So the activating event in this case would be the voice saying, controlling things, you're nothing, maybe giving commands to hurt oneself, leading to these depressogenic interpretations like, oh gosh, I got to do what they say. I don't have any power. I won't have any life, leading then to the fear and depression. And then the related behaviors, right? So isolation, complying with the voices, appeasing the voices, submitting. That's a big part of when people see their voices as powerful, which then can lead to decreased engagement, depression, inactivity, and sometimes self-harm. To the right is the column that's also part of the formulation more longitudinally, like early life experiences of being bullied can contribute to that. The social factors of just experiencing maybe discrimination as a result of having a diagnosis of schizophrenia. Or family members who may be critical, maybe based on misunderstanding and other things, can also feed that to some extent, contributing to the core beliefs of being vulnerable and weak. So that's one pathway, that's the psychological reaction pathway. The other is just the impact of the diagnosis on social status. So we're talking a little bit about internalized stigma and then just also insight. Now, there's an interesting thing called the insight paradox, which we've talked about in our trainings. And the idea goes something like this. When you have insight associated with psychosis, there's usually better treatment adherence, right? So I have something I need treatment for, so I receive the treatment. But it also tends to be associated with depression, lower self-esteem, and lower quality of life. Lower insight, of course, associated with treatment not adherence, and also, poorer outcomes in terms of psychosocial functioning, et cetera. So there's the paradox. More insights, you engage more, but you actually have more depression. And it's thought that this is moderated by this sense of internalized stigma. And this appears to be kind of borne out in some later research by Hassan and colleagues, where they added measures of hope into this assessment. And what they found was that when hope was measured and hope was present, they had that hope and optimism, that mediated the negative relationship between insight and quality of life. So if I had insight about psychosis, but I didn't think about it as this terrible, awful doomsday thing, I was able to frame it differently with hope, outcomes, quality of life were better. And so they kind of coined this phrase usable insight. Having insight with hope allows or helps the person to differentiate their identity from the illness to help them maintain hope in the face of symptoms. So part of our work then is to target that and help them generate that kind of hope. So that's really going to be what I'm going to talk about for the next 5 minutes. Like, how do we target treatment to kind of help them change tracks from the pathway or track of psychosis to depression, which is involved, which where their focus is on fear, loss of control, threat, powerlessness, a lot of those things. How do we help them to shift to awareness of safety, empowerment, being active, autonomous, and belonging? What are the things that we can do? And so for this particular presentation and this aspect of depression, we can target the things that seem to be correlated with depression. So what do the voices say? And then how do they appraise the meaning of the voice? We'll focus on that piece. One activating event would be there. This is again another plug to bring the family actively in. What are the interactions? How is the person, how do they perceive themselves treated at home? What are the power relationships there? And how do we work with that? And then helping to prime for like significant events and how do they interpret those events, with them being in the hospital, other things, is there stigma attached to that? Can we work with that? Now, the treatment approach, and I'm not going to go into great detail, but just to kind of highlight some of our most common strategies we talk about recurrently. And activity scheduling or behavior activation is a super popular one, both for negative symptoms and depression. And it makes sense, right? When people are isolated, they aren't doing things that bring pleasure, there's no way to get that reinforcement. So to the extent that we can help people identify and move in little steps towards meaningful activities, super helpful. And then the other piece, remember, with the metacognitive deficits, help them link those little steps with self-empowerment, with hope, asking those questions. What does it say that you're able to go to that activity, to go get a cup of coffee with your friend? And how was it when you did that? Integrating those together to kind of build that part. We do a lot of cognitive restructuring, obviously, looking at the voices and what they say and how do we interpret that, using evidence, how accurate or helpful is it to think about that way, looking at it from different perspectives. And then the other piece, when stigma is present, really bringing forward education around positive, hopeful outcomes related to psychosis, individuals who frame symptoms a little differently. And many individuals report positive outcomes even out of a very difficult experience like that. Bring that framing into perspective. Reality testing, a lot of different things we can do to kind of test the quality of voices. The other thing I'm going to spend a few minutes on is like, how do we intentionally, strategically help people to shift their attention, right? Have more attentional control and induce positive mood. So some of this thinking came from a manual, a book that came out a number of years ago, and Brian and I have been reviewing this lately. It's Cognitive Behavioral Prevention of Suicide in Psychosis. So they specifically looked at psychosis and how to reduce the risk of suicide. And the theory goes something like this, and I've already mentioned that the emotion system can become very threat focused when people experience psychosis, again, leading to powerlessness and defeat, and also narrowing their focus. And then it's thought that those two things really activate or keep the schemas related to depression and suicidal thinking more in the forefront or more active. So the goal is to teach attention shifting, ways to do that, and directing attention to other things away from threats and ultimately to more positive emotions. And, there's not like super fancy ways to do this. It's kind of the basics, right? Helping people to anchor in present moment with attention broadening tasks. So purposefully in session, helping them to do grounding, 5 senses that we talk about, practicing selective attention, changing their attention from internal self-focused thoughts to maybe external things that they could focus on, comment on, describe. We talk about the look, point, name method as one of the ways that we do that, so that they can learn, yes, I can shift my attention. And then the second component of that is using guided imagery to induce positive emotions. And that's the BMAC approach, broad-minded affective coping. And so what this is really an exercise you can do at any point in session. I like to do it at the beginning of a session, sometimes at the end. But the idea is, and you provide the rationale that if we can generate memories, positive memories, really connect with it, with the sensory details and the meaning of it, that brings it more into the forefront of our awareness. Having more positive memories or just our attention focused on that helps us to shift off of the negative things that are there. So momentarily broaden the focus. So very simple, we get into a relaxed state. we ask the person to think of a recent positive memory or a past positive memory and really spend a lot of time talking about the sensory details, walking through it in small steps, enriching it, right? And then connecting meaning to it. What does it say that you were able to have these positive moments? What does it say about you? What does it say about them? Where do you notice the positive sensations in your body when you talk about this? So to kind of strengthen that memory network, if you will. We have one slide here that kind of goes over the steps of it. We have a link and a reference if you want to watch the authors demonstrate this technique. But it's really kind of a guided imagery relaxation kind of thing, which I find, as I said, helpful to do at the beginning and end of sessions. So that's one part of it. That's one piece of shifting attention. The other part, again, remember the other piece of where depression can come from is current relationships and satisfaction within those relationships. And we know that when the individual perceives family or support of others to be critical, it has some adverse, effects, more severe negative symptoms. It can kind of reinforce some of the negative beliefs that the person has about themselves. So when that occurs within a family system, there's tends to be more overall stress and tension within the family system and more negative interactions. And so interventions here are really broadly what we talk about in terms of bringing family in to, first educate. Do you understand kind of what the process, what the person's experiencing, help them formulate it maybe a little differently. There's common misperceptions about, negative symptoms or depression being laziness or not caring or other things like that. So providing some more accurate information and a positive reframe, helping the family to generate some positive, maybe some different patterns. Are there ways that the individual can have more autonomy or more of a role within the family where they're more active and they can see themselves in a more kind of a higher rank position using the language of social rank theory. And also helping family members to kind of catch where there might be negative appraisals or blaming attributions and see if there are ways to work together towards a common goal where there's more positive framing and responses from the family that way to kind of work at it both. So you can work on the voices with all the attributions and then also work in current relationships and with both angles then addressing where the depressogenic thoughts are coming from. So just in summary, depression and psychosis is common. The two key areas that we covered today are in terms of driving towards depression is the psychological response to psychosis, and then the experience of marginalization and related internalized stigma are things to pay attention to when treating depression within psychosis. And then, CBT strategies to target, there's the broadening attentional awareness, which we kind of brought up and focused on a little bit today to increase positive emotions. So it's kind of a skill building kind of set, along with a lot of the other CBT interventions that help to facilitate an increased sense of control in relation to the voices. And then, as always, try to include the family and support systems to kind of create more positive reinforcing sort of patterns. So in the slide deck, there'll be some resources if you want to look at it, and the link, the broad-minded affective coping, if you want to see a demonstration, it's there.